Welcome back. Let's Get Physical Therapy is an educational podcast brought to you by MedStar Health and hosted by me, physical therapist Becca Schumer. I will be sharing the mic with tons of healthcare professionals with the goal of educating and inspiring fellow PTs and future PTs. We hope you find this both informative and inspirational, ultimately optimizing how we treat our patients and grow as professionals. Please enjoy today's episode. Today on the podcast, we've got Dr. Ali Carter. She's a psychologist at MedStar NRH Hospital, serving adults with various congenital and/or traumatic physical and medical conditions. She conducts assessments and provides interventions within inpatient and outpatient rehabilitation environments. Interventions are aimed to support mood, coping with disabilities, health behaviors, for example, pain management and sleep hygiene, and overall quality of life. She also serves as the Director of Training for Rehabilitation and Pain Psychology Fellowship at MedStar NRH. She is licensed in both Maryland and the District of Columbia. I really enjoyed this conversation with Dr. Ali Carter today. We dove into a lot about DEI, identifying our own biases. She talked a little bit about her own research and gave some good strategies for us as clinicians to utilize when we're treating our patients and to just better ourselves. So have a listen. Dr. Ali Carter, thank you so much for joining us on the podcast today. How are you?
I'm good. Thank you so much for having me.
Definitely, absolutely. We are going to continue our conversation about DEI, but first I want to hear about your story. How did you become a psychologist?
Oh, it's a long story, but I'll try to shorten it. I actually wanted to be an engineer, and then I got to undergrad, but I wanted to be an engineer. I started taking classes. So, oh, this is a bit complicated, and then so I thought I wanted to be a lawyer because it just sounded good. So I started taking criminal justice and criminology courses, and I was like, oh, this is boring. I don't want to learn about the law, but I was interested in criminology, like what drove people to be criminals, and so. Then I said, well, I'll just double major in psychology. And so I shifted gears again and said, oh, I want to study the achievement gap and I want to work with children. And so I graduated from undergrad and actually went to work in special education. And when I got to graduate school to work with a mentor who was doing that work, they had left right the summer before I was supposed to enter. So I was left without a mentor after I committed to the program. And one of the new faculty said, hey, I'm studying health psychology. And I was like, what's that? Told me what it was. And I said, okay, well, I'll give it a shot, right? And then I fell in love with it. And so most of my research and practice through graduate school was focusing on psychological and social factors that influence health outcomes. We studied the effects of perceived racism on obesity and acculturation on kidney function and hostility and suspiciousness on inflammatory markers. And I went on to internship and I applied for a fellowship at Hopkins. And I didn't even know rehabilitation psychology was a thing. It's not embedded in coursework. You don't hear much about it. And I said, well, this is a nice intersection of all the things that I love. It's patient-centered, it's understanding, the impact of society and its systems on patients. So that was like my passion around equity and inclusion and serving minoritized communities. And it infuses like the biopsychosocial model. So this sounds right. I'll just apply to it. And so I went to Hopkins for a 2-year fellowship in the Department of Physical Medicine and Rehabilitation. And then from there, I got hired to work at MedStar, and I've been here ever since.
Awesome. That is such a interesting, direction, journey to get to where you are.
Yeah, it's a windy road, which I hope normalizes for people that the path is not always straight. It's sometimes less about the process and more about the outcome.
That's helpful. I knew since high school I wanted to be a PT, and I never veered off that path. I was straight ahead. So I always wonder what it's like to not quite know what you want to do and how hard that must be.
Yeah. I work as an adjunct professor as well. And so a lot of the patients have so much anxiety because they have these sort of rigid ideas of the path that they should take. Like, I want to be this and stick to this. And, it creates this anxiety and fear around taking, a detour. And so what I try to normalize to students at that level is college is when you figure it out. Like, you don't have to have it figured out. Structured for majors and you're supposed to know, but like take the pressure off Be
Hmm.
spontaneous, be open-minded, give yourself some latitude to make mistakes and have different exposures. And, it worked for me because my job doesn't feel like a chore. Like I like what I do because my role was windy, if you will.
It's a good segue into talking about DEI. We got snippets of your passion when you're telling us about your journey, and kind of just in the field that you work in, you see the ramifications of what happens when we're not prioritizing these things. So what does DEI mean to you, and why is it so important in healthcare?
Sure. That's a big question. So, MedStar has conceptualized DEI. You'll hear it sliced and diced different ways, DEI, IND, the letters are switched up in the acronym, but the way that it's conceptualized and that I promote it through MedStar is EIND. So E is equity and sort of inclusion and diversity are vehicle toward that. So that's why the E is first and prioritized. So equity is an outcome. Inclusion is in action, right? It's including people of different backgrounds, thoughts, making sure everyone has a seat at the table, if you will. And then diversity is more of an adjective. So diversity in thought, demographic information, and these three things are interrelated, and you can't have one without the other. Now, and it's such a big umbrella term, but there's so many facets under EIND. So we could be talking about healthcare disparities, or we could be talking about inequities in staff pay, right? So it's so big, but it's so important for patients and staff because that's where, from a staff standpoint, if you don't have equity, inclusion, and diversity, the system does not work. It is equity, inclusion, and diversity that brings innovation, that brings talent, that brings a sense of belonging to the people here, the people that work in MedStar. And then if that is intact, we can better provide patient care, right? So patient care hinges on EIND and staff, right? You need a diverse and equitable and inclusive staff. And with that, then you can also widen the lenses of how EIND impacts patient care. So obviously, when we think about health disparities, which is also a big umbrella of terms, we know that there are minoritized communities tend to suffer more from lots of things like cardiovascular disease, traumatic injuries, all of the things that we see here. And if we don't have activities and initiatives that promote prevention strategies and intervention strategies, we actually are negatively impacting health outcomes. So it weaves through everything. It weaves through business, business strategy of an organization. It weaves through staff. It weaves through how we interact with patients. It weaves through the patients that we attract, how we care for them, the quality of care, safety of care, community reintegration. It is in everything. And so, that's a convoluted answer because it's hard to say, like, how does it work at MedStar? Well, it's in everything. It's in all things. It should be. So um, I conceptualize it as it being air and in everywhere and all things. Like it's important.
That feels like this huge mountain.
Yeah.
Where is a good place to start for someone interested in learning more about EID and how to be more inclusive?
Well, I love that you said that because it does feel like a huge mountain when you're in the work and doing the work because it is so pervasive. It feels heavy. The work is heavy, and people who are doing the work would say it feels like a mountain is on my back sometimes, like I'm carrying a mountain. And so I always encourage people to start small, right? When you think about the whole mountain, it feels overwhelming. It's like goal setting, right? It feels overwhelming when you think about reaching the goal, right? Equity. Like, how do you reach equity? If it was a simple problem, there will be a simple solution. And so I often tell people to start small, like in their sphere. And one thing they can do and should do before moving into this work is understanding bias, specifically their own biases. And we all have them. And so I want to normalize that because that can feel othering. It can feel off putting when you're like, examine your biases. And you're like, wait a minute, I'm the bad person. Why are you calling me out as the bad person? But we all have them. We all have them by design, right? If you think about things like stereotypes and unconscious biases, before we were like this integrated civilization, interconnected world, I mean, if you think about, prior to that, when we were on plains or, in jungles or mountains, or we lived sort of smaller, it serves me well to see someone who looks different to me and be like, wait a minute, you don't look like the people in my space. Let me get ready to protect myself. So by design, we are supposed to understand differences. Well, it's problematic now because we are around people who are all different in values and thoughts and visible characteristics. And so I always start with normalizing it so people don't feel attacked or threatened or afraid or fearful or guilty about starting there first. So owning your own biases. And then once you move there, like to not even think about that as like sort of siloed or isolated, that there are things that influence our biases. There's society and organizations and our country's history and the hospital's history and all the history. So understanding how your biases are shaped by these larger forces, I think that the work has to start there, if you will. So self-reflection, right, is so important. Moving yourself in spaces that are diverse and inclusive, recognizing your imposter syndrome when it feels uncomfortable, or you recognize, your privilege to understand that and not be afraid of that. I think is like so important. And that's the other thing that I encourage people to not to also think about their positions of power and privilege, even if they're a part of minoritized communities doing this work. I have power and privilege, and it serves me to understand that because it understanding my own power and privilege helps me navigate how I work with patients or see the world or others. And my lived experience is important. So I would definitely say self-reflection, and spending some time with your own thoughts and values and lived experiences and how what shape that is the first place to start.
Dr. Harrison just did an awesome podcast talking about imposter syndrome. So I'm going to put a plug in to go back and listen to that podcast if you haven't yet. When I hear you talking, I think if I'm thinking about my own biases, there's a lot of shame in it and admitting that we have these biases. But as you said, they do at some point protect us. How do we start? I know you gave some examples, but how else do we start to identify our own biases? What resources can we use? And then how do we start breaking them down?
Sure. So there are some like formal resources out there. So, like for example, the implicit association test is one that's public. You can just Google implicit association test, and there's different categories. So, like to tap into racial biases or gender identity biases, or you know internal ableism. It's sort of categorized, so you can choose which one or do all of them to for a good starting point if you wanted something more formal, to start to tap into your biases. But I think these conversations need to be normalized. Spaces in work and safe spaces and therapy with family, we need to normalize being able to put our stuff on the table in a safe and non, judgment free zone. Now that sounds easier said than done because first the space has to be safe. And so one thing, when I talk to people in larger organizations, one of the missions is how do we normalize safe space? Like it's just a thing. Like not that, oh, people feel timid putting their biases out there, but if this is normalized across spaces and organizations, if people are willing to do it, and it doesn't feel as scary. And so when people are afraid to, for peer consultation or, I'll speak to the work environment. Like as psychologists, we do supervision and consultation because we work with so many people. So it's important to have a space where our colleagues can say, hey, did you think about this? Or how do you think this part of your experience influences your interaction? We have sort of those deep conversations, but because it's just a tenet of psychology, we expect it. It feels okay to bring that to the space. So I encourage people to create spaces that are safe, that they can talk out loud to people, and to have some reflection on to help in their reflection on their biases. So safe spaces, whether that's formal or informal, with therapists, with colleagues, whatever makes sense, and organizations through HR, EAP, whatever that is. So there's the creating spaces, there's tasks like the IAT, journaling, and being around people that are different from yourself, right? I think that is so important to take note of visceral responses and data points and this idea of meta thinking, right? When we think, to not just think, but say, like, why am I thinking that way? What influenced my thought there? Like, so it's thinking about your thoughts, which we're not really, we don't really do. We just think. We don't think about our thinking. If you asked me what's my favorite food, and I said, oh, spaghetti. That would just roll off my tongue. But then saying, well, why is spaghetti my favorite food? How did I come to that? What influenced that? What were the earlier experiences I had? How do I know I don't like other things than spaghetti? Like that type of meta thinking, I think needs to be practiced. It's a skill that can be developed and it's important. And so I gave a silly example about spaghetti, but that is also true for emotionally charged topics. Like, why do I think this way about race or power or privilege or, insert whatever. Like, and, maybe practicing with reflecting on why that's your favorite food is a good starting point. But that type of meta thinking, I think, is really critical to understanding biases.
And once you go down that thinking path and challenge your thoughts on why these biases might occur or exist,
Mhm.
what's the talk we can give ourselves on why it's so important to challenge these thoughts?
Right. So the first thing I, the first thing that I want to say is while we're thinking and these things are coming up, like, wow, I think that way, and I just realized I think that way. I think giving yourself grace is important, right? Because once you start to be hard on yourself, you stop the process. It gets too uncomfortable, right? People don't like feeling vulnerable. So I think this normalization of cultural humility, that this is evolving and ongoing and on a continuum, and you're a learner and you're curious about yourself and others, just framing it that way, putting it into that framework is important, or else the work stops. When you start to beat yourself up, right? The work stops. And this idea of it being on a continuum. So, for example, I do a lot of self-reflection. I think about EIND a lot, but it's not an endpoint, right? People think about biases very dichotomously. So I'm biased or I'm not. I'm racist or I'm not. I'm sexist or I'm not. I'm insert a ism. I'm that or I'm not. And that's a disservice because when you put an endpoint to it, the growth stops. So you have to think about this as being on a continuum. So if you find yourself saying, whoa, I just uncovered this thing, know that there's still more work to do. Know that that is the process. The process is uncomfortable and you are uncovering it, and that there can be action along the way, but the action never stops either. That this is a continuum. That should be a part of your pep talk. Like, this is the process,
Hmm.
if that makes sense.
No, it definitely
Yeah.
does. What are some recommendations? Say, I did all this work, I'm feeling good, I'm not having these biases, I'm treating everyone equally, great world, happy world. But I'm noticing my colleague is acting on their biases or treating patients unfairly or, whatever. What's a good starting point to have these conversations?
Right. So, one, I would say I would never recommend saying, I'm done, right? So, world is a happy place. I'm treating people fairly, because that's the
Sure.
thing about unconscious bias, but it's unconscious that, you don't know till you know, and it shows up in so many different ways. Like, maybe I think I'm a fair person, but then when I really look back, I spent less time with this patient than that patient. And why was that, right? If I'm So I would say never get to a point of being comfortable, like be comfortable with being uncomfortable. But if you notice, and I think, to your question about what happens if a colleague does something that you think needs some exploring, this is where I think it's important that we're creating an organization where we can have these safe spaces. Because if you're the first person saying to this person, or the first time this colleague is even being challenged to think about biases, that could bring up a person feeling defensive. But if this is an organization that from top to bottom has rolled out implicit bias training, has said these are the tools we want you to use, this is how we do it, it feels more comfortable. You as a person then feels more empowered, like, oh, we talk about biases all the time. Let me just bring this up to my colleague. So, that's to go back to you saying carrying a mountain, that the work can't be done one person at a time. Like people who are a part of organizations like MedStar, whatever organization or space people are a part of, it needs to be normalized. These conversations need to be a part of the culture, whether it's starting every staff meeting with safe space rules or normalizing biases. But if the work is only falling on the EI&D committee and is not pervasive and present in all meetings and all staff members, then it can feel uncomfortable to call someone out. I mean, you could think about, as a psychologist, when we have to call people out on difficult things, one thing I would say is I never present myself as, expert of all things. Like I do the work, but I'm in it just like you. I'm still learning. And so I tend to use open-ended questions to challenge thought. I tend to use Socratic questioning. So that's, hey, I noticed you said this. Could you tell me a little more about that? Or have you ever thought it this way? Or what, like you're questioning gently. And if you don't feel comfortable, depending on if it's egregious, then that's a different story. If someone did something really, really egregious, you might want to have something more formal in place, like, bringing in leadership or HR or whatever the case is. But for things that aren't egregious, things that don't cause harm, or, subtle things like a microaggression, you could potentially, if the space is safe, and you're feeling comfortable, ask open-ended questions or be frank. Hey, I noticed you said this. That could be a little bit offensive to some people. I've noticed myself in that situation sometimes too. And this might be a better way to think about it or a better way to say it. And normalizing growth and curiosity. So it is hard when it's not a part of the organizational culture though.
I know for physical therapy, part of our requirement to renew our license is to take some kind of biases educational, like continuing ed education class.
Mhm.
But just doing that every 2 years is not enough to dive
Mhm.
into our
Yeah.
biases and really work on them and challenge them.
Now, experiential learning is the best way to do it. So activities and workshops where you are in the moment having a visceral response and being uncomfortable, right? That's the best data, these experiential activities. And same for psychology licensing, that we have to take, implicit bias training, which is just reading, and people just want to check the box because it's one more thing they have to do. It's not I shouldn't say it's not impactful. For some, it might not be as impactful. It's really the visceral learning, the in the moment, the aha experience. I think that you get the most bang for your buck.
I'm going to take a left turn because I know, like, again, you've emphasized how huge this topic is, but I'd love to hear more about the research that you've done or are doing and dive into that a little bit.
Sure. So currently, the most current project that we're doing, we're actually in manuscript preparation phase, is we wanted to understand why our medical rehabilitation population were not attending their outpatient scheduled appointments. So once they're discharged from National Rehabilitation Hospital for their acute inpatient stay, they have a scheduled outpatient appointment on the books, but a significant number of folks were not showing up. And I mean, I'm talking about like 3/4. Like it was a huge number. And we're scratching our head like, what is going on? We know people want to be well naturally. People don't wake up and say, hey, sign me up for declining health. Like that's not how people work. So, we know these patients from the inpatient unit, what is going on? And so, and we saw the trends for 2020, and so we decided to do a qualitative study. So that's asking people with interviews their lived experience. We knew that sending out surveys or asking people to check boxes wouldn't get the data that we needed. We really wanted to understand their lived experience, and so we went back to the patients who had missed their first scheduled therapy appointment, so PT or SLP or OT or with a physiatrist or psychologist, and we asked them, like, could you tell us, in your experience, what made it difficult to get to this appointment? So never blaming, never saying this is a you issue. We're very intentional about the language that we use because we understand appointment attendance is, there's social drivers to that. And so what we uncovered, one is transportation is a huge barrier, which is consistent to national data that transportation is the biggest barrier to, medical appointments and for persons with disability. And then what came up for us second is our communication system at the hospital. So the hospital is a social determinant of health, right? When we say social determinants of health, people tend to think like transportation and food insecurity and all these things impact health. But the way that we do things in the hospital is, could be problematic. So there were lots of things patients didn't, and providers, let's be clear, because we interviewed patients and providers. They don't use, and at least in our sample, were very unfamiliar, if familiar, so they may have been familiar with the patient portal. However, they did not know how to use the patient portal. They weren't being instructed. Even some of the providers was like, use it. So, we have this system in place to be able to communicate with patients, but it's not being used effectively. That's a system issue, whether that, how easy it is to navigate, but that maybe we don't have, the way that we present job aids to providers, if that's effective, but that was an issue. People aren't using the patient portal as much as we would like patients to. Also our notification system. So, patients talked about, they're calling the landline. I prefer text. They didn't call my caregiver. They called me. I don't know how to work a phone or cell phone. Send me a paper. Just so many different individualized concerns about the way we communicated their appointment, difficulty scheduling. There's no uniformed process for informing patients about appointments at point of discharge. Sometimes it's the case manager, sometimes it's a physiatrist, sometimes it's a nurse. So it was so much that came out of that. But I guess the main takeaway is the way that the hospital communicates to patients and notifies patients is a social determinant of health. That if patients can't get to their or know about or are able to reschedule their appointments, that is a disservice to them because we know not coming to appointments leads to lots of issues. So more pressure wounds and, difficulties with bone health and poor functional outcomes. I mean, all the things, right? So what we're doing now is writing that up as a paper and, it's been presented to leadership. So we're looking at, as an organization, about ways to improve the way that we communicate with patients or the process in which we communicate with patients, as well as trying to problem solve around transportation.
Very cool. So any solutions that have been brainstormed to work on these things?
Yeah,
If you're able to share.
Yeah, some solutions. I would say most of the solutions are in the infant phases, but I will say we're trying to promote the use of Z codes. So Z codes are codes that in ICD that indicate sort of social concerns. So housing insecurity, food insecurity, transportation difficulties, decreased social support. So social concerns. And these would sort of populate in the patient problem list, right? Problem list. I'm doing air quotes there. But what it would do is, when providers are looking at a patient chart and they see spinal cord injury or obesity or amputation, they'll also see transportation difficulties. And that hopefully will prime providers to say, oh, this is a problem. Well, maybe I can provide resources, or maybe I can be more intentional about when, how I schedule their appointment. And so we think that that may be an opportunity to mitigate issues around transportation, or whatever the case is. Now, is that the fix? No, because it's transportation as a system issue too. Like paratransit services have so many issues: cost, availability, issues with time. I mean, I'm sure you've heard patients talk about the issues that they have with transportation. But this goes back to focusing on what's in your sphere to try to make impact versus trying to move the whole mountain, because that feels overwhelming. And I think it's easy to get stuck and take inaction when you are thinking, well, how can I change the world transportation system? Like that, that feels large, but can we just put a Z code up as a point of, conversation with the patient? That feels more manageable. So that's one thing that we are promoting, and the use of Z codes. We're also looking into other grants that might be able to support financially different transportation resources. We, are pushing people to think about, one of the quotes that came up in our study was the patient saying, I thought I would be able to have transportation, but I really probably should have did home health PT or OT initially. I mean, I'm obviously summarizing; those weren't their words exactly, but quote to speak to overestimation of support in the community, or overestimation of, you know, how easy it would be to reintegrate into the community. And so, even just promoting more thorough discussion and questioning around discharge planning would be important. So we have lots of ideas, and as things come to fruition, we will make sure to roll that information out, or promote whatever initiative or activity through the network.
Awesome. That's really great stuff. I'd like to talk about power differential. You kind of alluded to it earlier about being in a power position, given the field that you're in as a PT to our patients. There's a power differential. How can we reduce this with us and our patients and make it a more equitable experience?
Right. So I think, always point one, like being aware of your own power and privilege. Like for me, young, I identify as a Black woman. Well, I think I'm young. Some people might not think I'm young, but I'm younger in my career, right? And so in this space, right, I may have more, in the professional space, I would say I have minoritized identity, but I hold a lot of power and privilege, right? I have a PhD, and, so being okay to say I hold privilege and power in this space, and that's going to change, right? Your power and privilege and salient identities ebb and flow depending on the environment you're in and who you're with, but recognizing that you have power and privilege is important, and that insight helps you navigate relationships with patients. We know that, just from data, like, patients do have better health outcomes when there's concordant relationships, like whether concordant by gender identity or race identity. Not, and it's not because I can talk to another Black woman, our lives could be completely different, but there's a meta communication there, an assumption that this person gets it. So in their mind, they've reduced the power differential, even though it's still there. But, so we know this, reducing power differentials, perceived or objective, are important. So one, I think it's important to know how power shows up. Right. So, power shows up in immutable ways like age and race. I in my age and I'm in my race, and I probably could change how I look to be different. But for now, I would say, for this conversation, I'm immutable. Um, or it can be, tangible. So doctors wear their white coats, and that's a sign of power. Or, you see sorry, husband, I don't wear, my diamond wedding ring because that's communicating, hey, look, again, not explicitly, I'm using hyperbole and being sarcastic, but I'm walking into a room with a patient with, a diamond wedding ring on. There are assumptions that that patient's going to make about my diamond, about me being married, about me being a doctor that might already make them feel less than or like I don't understand or not going to listen, right? Then there's intangible ways that we communicate power, like our style of communication. I will, I have a chair that I can adjust. I make sure my chair is at eye level with whoever comes into this room. I work with people who are wheelchair users. I'm at their eye level. I try very, very hard not to talk over people. The pace of my communication, the tone, educational differences in my office. I have all these fancy plaques about my PhD and master's, and I went here, and that makes me feel good, but that can be intimidating to some patients. So just being mindful, and because I'm a psychologist, patients expect me to say things that are, uncomfortable. So I see you looking up there. What are you thinking about that? I get that. I have, people expect me to do that because I'm a psychologist, but that may be more difficult to someone who has a job title that's not associated with being nosy or intrusive, right? So I get that I have privilege in that way that I can just, hey, in this space, let's talk about how me being Black is going to affect this process. That's uncomfortable. But I think understanding how power shows up, one is really important. So you can modify as feasible to meet the patient where they are, right? And I say patient because I'm in a hospital, but sometimes just calling somebody a patient affects, the power dynamic. So being mindful of that, like it shows up in so many ways. And so just being creative about how you think about power, I think is important for your own discipline. Other things that we could do to reduce power differential. So whether that's modifying the environment, may say, hey, let's meet outside, right? It feels less intimidating to meet outside than you being in a hospital bed and me towering over you, right? That feels less intimidating. That's you get what I'm saying?
Mhm.
So one, I think environmental modification, being mindful of how you look, how you dress, is important. And it might be important to leverage power sometimes.
Sure.
I go into rooms and, people who need, I shouldn't say need, people who may request psychological assistance, I come in and they say, who's this? Who's she? Like this child. I have more gray hair in my hair than her. And I'm a doctor when I'm not in the hospital. And so sometimes leveraging power actually helps me to connect to patients. So it's not a it's not easy. It takes a lot of thought power, a lot of cognitive domain to think about that. Listening, I think that is something that we all could do if we have, the ability to listen. Listening is so important. There's research to show that patients may speak uninterrupted for, I'll let you take a guess, Rebecca, how many seconds before they're interrupted?
12.
Yes. It averages 12 seconds and are interrupted twice. Um, I am doing primary care talks. I think we underestimate the power of listening. We are experts at what we do. I don't want to take that from any professional, but it's also important to see the person as the expert on them. And every interaction is the meeting of two experts. And so not falling into what we call traps in like motivational research. So like the expert trap, like I know more than you know. Um, Obviously, we're not saying that to patients, but our style of presentation, interrupting them or presenting education that they probably already know or aren't ready to hear. Like that is increasing power differences. You creating the assessment or treatment plan or the focus of treatment can indicate that I have power here and you don't. So shared decision making is important. Collaborative goal planning is important. Labeling is important. So, I find I read some charts sometimes, and these are good, well-intended providers and, their buzzwords throughout the chart that like non-compliant or non-adherent or refused or, these words, and immediately that is communicating something. That's going to create bias in some people. If I see a chart and it's like, oh, this patient refused this, non-compliance to medication, there is a picture that comes up in my head of this person being problematic. Maybe this person isn't doing what they're supposed to do. It's blaming, it's labeling. And so I think understanding that people exist in systems is important to prevent blaming and labeling, just like our study. Like you didn't show up to your appointment not because you didn't want to. Metro Access didn't show up because you didn't get our phone call. That's not a you issue, that's a system issue. And so I think a part of being able to reduce power differentials is not blaming the patient for judgments that they make or decisions or any of that stuff.
I think that circles so nicely back to the beginning of our conversation about the importance of us identifying our own biases. As you're speaking, I'm just thinking how paralyzing it can be to analyze every single thing that I'm doing. Like, is my shirt tucked
Yeah.
in well enough?
Yeah.
Is my necklace going to make them, is it going to trigger a response in my patient?
Yeah.
I know as a psychologist, you're aware of all these things. And as a clinician, it's just, there's so many things you have to think about.
All the time, all the time. Anybody that I like to think about it. If you're here in the hospital, you've lost some power. Just you're a patient and everyone else is a provider, right? I work with people who have spinal cord injury. You've lost function, you've lost privacy. You are already in a lower position. That is hard. That is a hard switch. Okay. And so sometimes that's going to manifest as irritability or avoidance of activities or all the things that drive a team crazy. And so, I had a supervisor a long time ago once tell me we have behavioral concerns um, on the unit when I was on fellowship, and they said, "I don't want people ever to think this person is angry, but they're scared." And when does fear come in? Fear comes in when there's uncertainty. Uncertainty likes to live where you don't have power, right? So I think if you peel back the onion and look hard enough, that when we think about patients that we serve in the hospital in their positions, that we can probably have more compassionate conceptualizations about how, what we perceive as maybe difficult. I think that understanding power and biases helps us bring compassion to that space, if that makes sense.
It makes a lot of sense. Dr. Ali Carter, I know we could go on forever on this topic and go down many rabbit holes, but
Yeah.
time is
Because
coming
I
to an
talk a
end.
lot. A nice way to tell me I talk a lot, Rebecca. Thank you.
I did not see that. Also, I was sort of a cheater because I already knew the 12-second stat. So
Okay. Yeah.
that was not a guess.
Listening
No,
is hard.
it is
Yeah.
for
It's
sure.
hard.
We like to end our episodes with favorite quotes. I would love to hear your favorite quote that moves you, drives you, inspires you.
Yeah. So mine is from my father, actually, who I love so dearly, and he's been saying this to me since I was a kid. He tells me, "Yes, man makes plans, but God makes decisions," and that has been really helpful for me because every day I walk into work is unpredictable. I'm a mom. That's unpredictable. I mean, like I'm in so many roles where things are unpredictable. I work with so many patients who, um, remind me that life and health is fragile. And so that is something that grounds me and shapes my expectations and my gratitude and self compassion when things don't go my way. So, yeah, man makes plan, God make decision, but insert whatever gender in there and it's still applicable.
Love it. This has been an
Yeah,
amazing
thank you.
conversation. I so appreciate you taking the time to speak with us today. Where can people find you?
At MedStar. I'm at NRH. I'm there most of the time. You can find me on the chat. You can email me. I'm in the directory. But yeah, I'm at NRH on 2 West. Shout out to the spinal cord injury team. Amazing. And yeah, I'm here. Reach out anytime.
Sweet. Thank you.
Thank you.
Thanks for listening to the Let's Get Physical Therapy podcast. Be sure to subscribe to our podcast and follow us on Instagram at MedStar Health PT. If you've enjoyed today's episode, please give us a 5-star rating and leave a review so we can reach more listeners just like you. As always, we appreciate your time and hope you join us for our next episode.